For our next speaker, we have a real international, he might say just national, but I'll say international expert on colorectal cancer screening and surveillance. Doug Robertson is a professor of medicine at Dartmouth and the chief of the VA at White River Junction. Doug, welcome.
All right, great. Thanks so much. Thanks for that nice introduction. And I want to thank both Gareth and Eric for inviting me. It's so wonderful to be here with you in sunny California. So I'm going to cover a few abstracts as well, and then I'm going to also have a state-of-the-art talk in a few minutes. But let me go over a few abstracts that struck me from DDW. The first one is maybe a little bit of a chip shot for me. I mean, this is data that we presented at DDW this year. Actually, my co-first author, Dr. Jason Dominance, who's the co-chair of this large clinical trial in the VA with me, the CONFIRM trial, actually presented these results. And the title is Long-Term Annual and Biennial Fecal Immunochemical Test Adherence in a Multi-Center Study of Colorectal Cancer Screening. So, why might you care about FIT screening? I do think, and again, I was talking with Eric just before the session, I think there's growing interest in non-invasive testing, particularly as a way to improve adherence. They published a paper, I think as a brief report, both he and Dr. Folomé, I think were the key authors on that paper, and showed that, during the pandemic, and others have shown this too, right? We're using a lot more non-invasive testing with FIT. But I think that one of the real potential Achilles heels of FIT testing is the need to do it over and over and over again. And so what this abstract is about is, what is the long-term adherence year by year in a large FIT program? And so we looked at that within the framework of our clinical trial. We also looked at predictors of adherence to see if we could understand the kind of things that predict regular adherence to FIT screening. So again, I assume many of you don't know much about the CONFIRM trial. So this is just an overview of that study. It's a large randomized controlled trial where folks are randomized 1-to-1 to either screening colonoscopy or annual stool testing with FIT. We recruited average risk adults age 50 to 75 who were due for colorectal cancer screening. The primary outcome of that study is colorectal cancer mortality. I'm not going to be able to tell you about that today, but I'm hoping you invite me back in a decade or so, and I can go over the primary outcome results. We did finish our recruiting in 2017. And again, we do suspect we will probably have main study results somewhere in the range of 2027. Again, we recruited across the entire United States. And so again, we don't have a lot of year by year adherence data in the United States. And so this, at least in that way, is a very representative study of the population, with the limitations that it is a VA clinical trial. So the aims were to determine the longitudinal FIT adherence in the CONFIRM study and determine predictors of longitudinal FIT adherence. This is just a high-level overview of the study. Again, this would make sense based on what I just said, right? We recruited 50,000 individuals, essentially flip a coin, randomize them to colonoscopy or FIT testing. If they're positive, we refer them for colonoscopy. If they're negative, they stay in that loop for 10 years. But the real point of this slide is to highlight that, again, today what I'm telling you about is the people that are staying in that FIT loop. And the study's been going on long enough now that we actually have a fairly large group of participants who've now had 6 opportunities to be screened by FIT. Since I'm talking about adherence, I think it's kind of important to understand what we do to try to improve FIT adherence. And there's a lot in this space going on right now. There was actually a large symposium looking at mailed FIT and how to improve adherence with mailed FIT. We do believe that we're generally following best practice in terms of how we apply FIT. And so this schematic just shows, if you start at that top bubble at the start, we actually do send a primer letter about 45 days before we send the mailed FIT. And so to try to improve adherence, we send this primer letter. The first mailed FIT then goes out. We wait another 45 days for that kit to come back. If it doesn't, we send another kit. And then if they fail both those opportunities to screen, both kits, we then put them back in the queue for the following year. So every cycle is a primer letter, a FIT kit, and another FIT kit. So we work fairly hard to try to get folks to be adherent to FIT screening. A lot of the analysis I'm going to show you is just basic numeracy, just basic adherence rates. I'm just going to very briefly touch on some multivariable logistic regression we did looking at predictors of annual adherence. And again, we have a lot of baseline information. As you can imagine, it's a large clinical trial. They completed a long survey. So we know a lot about, their sex, their age, they self-identified their race and ethnicity, their body mass index, habits, et cetera. So we know a lot about them, and we included that type of information in our modeling when we were looking at annual adherence. So what do we find? So this is the first results slide, and I'll take you through this just a little bit more slowly, and then we'll speed up as we go along. We randomized, I said, 25,000 folks to annual fit screening. So in that first round, 17,360 completed that first fit. So 81% adherence in the first round of screening. Now, if you were fit positive or you got a colonoscopy for any reason, you're not eligible for fit that following year. But in the 23,000 people roughly who were eligible the second year, 67.9% completed a fit. So you can already see some degradation of that adherence from 81% at round 1 to 67% at round 2. You also see that the fit positivity rate dropped from 7% here to 5.7%. And then as you continue to move along, you can see that adherence continues to fall to 64%, 63%, 61%. And out at that last round, round 6, we're down to about 60%, 59.2% adhering with screening. And so you get some sense of the data, right? It's difficult for people to complete fit on a yearly basis. This is just another look at that data. I've already given you this top line number that the baseline fit adherence was 81.6%. 87% of our population completed at least one fit. In terms of the kind of the 6 for 6, the home run hitters, the 6 for 6, only 44% of our population was able to do all 6 fits they were offered. And then this issue of biennial fit is important because, again, in the United States, we have a tradition of doing annual stool-based testing, but in Europe, they do much more biennial testing. And so 61% of our participants were able to accomplish one kit every other year. And then very briefly, and I'm going to move on more quickly to my other abstracts, it's just this idea of these multivariable predictors. And again, I'm not going to belabor this. Many of these factors kind of go in the direction that you'd suspect. So for example, smokers were less likely to be adherent to annual fit testing. But one thing that struck us, and it has us reflecting a bit, is that we actually found some racial and ethnic variation in adherence over time. And so we found that Blacks were roughly 50% less likely to accomplish annual adherence. And when you looked at Hispanics compared to non-Hispanics, about a 25% reduction in annual adherence. And I think, again, we do a good job in some ways of applying fit testing, but perhaps we haven't gotten it quite right. And I think this has us reflecting about how we communicated with participants and whether there were things that we could have done better. I mean, we're very proud of is a very broad-based study. I think we have about 25% African Americans in confirm, about 14 or 15% of people ascribing to Hispanic ethnicity. But again, in terms of accomplishing repeated adherence to fit, maybe we're missing the mark a bit. And so in the interest of time, I'll just go to the conclusions that we have ongoing efforts to improve longitudinal fit adherence are needed. Again, we know that race is a proxy for social determinants of health, but we need to better understand how to mitigate the gaps in fit adherence. And so that's something that we've been reflecting on. And again, I'm only showing you adherence to fit. Future analysis are going to also show colonoscopy adherence and compare fit and colonoscopy adherence. So let me move on to a couple of the other abstracts. And again, I'll cover these more briefly. The first one is, again, another AI. So you heard about that CADX study. This is really a CAD-E study, artificial intelligence assisted colonoscopy for adenoma detection in screening colonoscopy, a multi-center randomized controlled trial. So I think what caught my eye about this is that this was a large randomized controlled trial of AI in asymptomatic folks across 6 referral centers. They were randomized to AI or standard colonoscopy in a 1-to-1 ratio. The primary outcome was adenoma detection rate, but they also report important things like differences in time and advanced adenoma detection rate as well. And so again, I'm going to make this easier for you to see in a second, but I'm starting here just to show you that the AI group is on the left, standard group is on the right. And again, there's about 3,000 participants, so a fairly large study comparing AI to standard colonoscopy. So let's look at the results. You can see here, and I don't think this is surprising, certainly on the withdrawal time side, but both the intubation time and the withdrawal time was longer in the AI group. And of course, it's impossible to blind these studies, and it came up in the QA. I mean, of course, some of the findings that I'm going to show you next, it may just be related to longer looking times in a way. But again, they did experience slightly longer intubation and withdrawal times. So the main result is shown here that adenoma detection rate was increased. So 41% in the AI arm, 33% in the standard arm. But I think the most striking thing for me, and this is where there's less sure data, they actually found a difference in advanced adenoma detection. I think we all would agree that's the important metric. And so they found a 6.6% advanced adenoma detection rate in the AI group compared to 4.9% in the standard group. And again, I'm going to show this slide again in my state-of-the-art talk, but essentially, I think we have a well-done meta-analysis that was published last year. I think we know that AI generally is going to increase the detection of small polyps, so 40% to 23%, 12% to 8.9% for these 6 to 9 millimeter polyps. But larger polyps, again, this actually did not reach statistical significance in this meta-analysis. But I think this paper that I just showed you would be another paper on that greater than or equal to 10 millimeter chart. And again, I think perhaps we are moving to this realization that AI may improve our advanced adenoma detection rate as well. So continuing along, again, I mentioned that AI detects more small polyps. So I wanted to present this paper, a randomized controlled trial investigating cold snare and forceps polypectomy among small polyps in rates of complete resection, the tiny polyp trial. So again, I do think with all our efforts to improve ADR and AI, we find a lot more small polyps. So when you find these really small polyps, what's the best approach to resection? And I think this is something I think about in my own practice as well. So does cold snare polypectomy offer an advantage over cold forceps for polyps less than equal to 3 millimeters? Single center study, people were undergoing colonoscopy for any indication. Individual polyps underwent block randomization, and 2 marginal biopsies were taken to look for complete resection. Again, the primary non-inferiority outcome is there. It doesn't really matter at the end of the day. I'll do the same kind of thing where I show you the overall results here. So cold snare to the left, cold forceps to the right. You could see there's about 260 people in this clinical trial. And incidentally, this was a DDW abstract, but this is being published in the Red Journal kind of as we speak. So if you're interested in this, you could look at your Red Journal and see all the results. One interesting thing is a fair amount of these tiny polyps were adenomas. So about 80% in the snare group and 66% in the forceps group. But in terms of the actual main results that I wanted to present today, the positive margin biopsies were identical between the cold forceps and the snare. So 1.4% in each group. It did take more bites with the forceps. That probably doesn't surprise you. Mean polypectomy time was actually a little longer in the snare group. I wonder if this has something to do with hunting for these tiny polyps after you snare them off. And then I wanted to leave this final message with you related to this study, which are these US Multi-Society Task Force guidelines, first authored by Dr. Tanya Kaltenbach. Again, I'm the current chair of the US Multi-Society Task Force. We do make some recommendations about how to remove diminutive and small lesions. We lump them together. We favor snare, although again, this paper would say that, perhaps for these very tiny lesions, forceps is adequate. But I think I also wanted to highlight this last bullet, that we recommend against the use of hot biopsy forceps for polypectomy of diminutive lesions and small lesions. And I suspect that's not being done often in the room, but I really wanted to highlight that recommendation because I don't think that the risk of doing hot biopsy forceps justifies that technique. And there's actually data that it doesn't do such a great job at removing polyps completely. Again, I'm going to cover this paper pretty quickly, but we are finding a lot more small polyps. So this paper is basically asking the question, if you keep finding more and more small adenomas in your practice, are you kind of preventing more and more interval cancers, right? I mean, we've had data for a while, initially coming from Mikhail Kaminsky's group, that those endoscopists that find more adenomas have a lower risk of subsequent interval cancer. But in the first study by Kaminsky, I mean, the threshold that they found was incredibly low, right? It was like an adenoma detection rate above and below 20%. So the question becomes, as we find more and more and more adenomas, is that really benefiting our patients in terms of reducing interval cancer risk? And so the study question was, is there an upper limit to ADR beyond which further improvement does not result in significant post-cancer reduction? Again, they're using this Polish colonoscopy screening data. So I'm going to put the figure here in a second, but I just want to orient you to the slide. So on the y-axis is going to be the post-colonoscopy colorectal cancer rate. And on the x-axis is increasing endoscopist ADR. So what did they find? Well, what they found is up to about 23%, you see this really sharp downslope. So very small gains in improving ADR is associated with significant decreases in post-colonoscopy cancer rates in this range. But as you go farther out, you definitely see kind of a flattening of this curve. And so there's only a 2% decrease in post-colonoscopy cancer rates with every 1% increase in ADR after this kind of threshold that's somewhere around 23%. So what's the take home for your practice? I mean, obviously you continue to have benefit as you go to higher and higher ADRs, but to the extent that you're a practice manager, right, the real juice to be squeezed is in those folks that are really performing at these low rates of adenoma detection. Improvements there yield really large improvements in reducing subsequent colorectal cancer after colonoscopy that didn't detect it. Finally, 2 abstracts about diverticular disease. I don't know if we talk about diverticular disease enough, and it's very common, obviously, in all our practices. So 2 quick abstracts about that. The first one was this: healthy lifestyle factors and risk of incident diverticulitis among women. These folks were asking the question, what is the impact of diet and lifestyle on risk of incident diverticulitis? And so again, I'm sure we're all scoping all the time. We're finding these lesions, and some patients want to know, is there anything I could do to prevent problems, doctor? So maybe this is some data that helps answer that question. So they use data from the Nurses' Health Study 1 and 2. Again, if you're familiar with the Nurses' Health Study, it's great, based out of Harvard. They prospectively are sending questionnaires to folks all the time. They have a very good handle on both exposure and outcome. And so basically when they find or someone raises their hand that they had diverticulitis, they actually go confirm it in the medical records. And then they use Cox proportional hazards to examine the association between risk factor and outcome. So what did they find? So again, I'm going to boil this table down for you. Don't be overwhelmed by all the data. I'm just showing that they have data from these separate iterations of the Nurses' Health Study. Nurses' Health Study 1, Nurses' Health Study 2. I am just going to focus on the pooled results. So I'm going to pull those results out and just focus on the pooled results. So what did they find in terms of diet and lifestyle factors? Well, what they found is things like higher BMI was associated with an increased risk of incident diverticulitis. Smoking, to a lesser degree, was associated with increased risk for diverticulitis, and an increased intake of red and processed meat. Again, more modest than the ORs that you see for body mass index, more modest increase. But again, there was some evidence that red and processed meat increased the risk of incident diverticulitis. On the positive side, more physical exercise and higher fiber intake were beneficial factors in terms of reducing the risk of diverticulitis. And so again, encouraging people about these common sense things: losing weight, stop smoking, more fiber, less red meat, all those things. When you find those diverticuli, you could tell your patients and feel good about it. There's some real evidence that it makes a difference. And then finally, this was the other result slide from that abstract. It's like every little bullet helps a little bit more, right? So if you're able to modify 1 risk factor, 2 risk factors, 3, 4, and 5, you get more and more of a risk reduction. So every little bit helps in terms of modifying your risk for incident diverticulitis. And then finally, I'm sure everybody in this room who's an endoscopist has one time done a colonoscopy because someone recently had a bout of diverticulitis, and there's this concern that they can have colorectal cancer. And so the title of this abstract was Risk and Predictors of Colorectal Cancer in Patients with Acute Diverticulitis, a large cohort study in a diverse US population. So the background here is that, I think, as you know, colonoscopy is recommended, but predictors of colorectal cancer in patients with prior diverticulitis is poorly understood. And so could we understand better who's really at high risk to have a colon cancer? I mean, that's the question they're trying to answer. So they use data from the Kaiser Permanente Northern California data set. They use coding to identify incident cases And then they, again, had those confirmed by CT. Interestingly, they used natural language processing to stratify cases into complicated cases where there was an abscess, obstruction, or perforation, and uncomplicated. They then, again, using that KNPC data, looked for colorectal cancer incidence in the following 2 years. And they did compare it to the general KNPC population. So one result I'm going to show you is just as any uncomplicated or complicated diverticulitis increase your risk relative to the general population. And then I'm going to look at predictors of colorectal cancer after diverticulitis in the second slide. So the first result is here. So compared to the KPNC general population, the standardized incidence ratio for uncomplicated and complicated diverticulitis were 1.94 and 5.30 respectively. So there's two messages, right? It doesn't matter whether it's complicated or uncomplicated. Each was associated with an increase for subsequent cancer, but there is a pretty big difference, right? Complicated diverticulitis has a far higher standardized incidence ratio than uncomplicated diverticulitis. So that's one message. And then they also wanted to understand other predictors beyond just complicated and uncomplicated. And so some of the key findings, again, are shown here. Advancing age was important. So I think that makes sense, right? Like the pretest probability of having colon cancer goes up as you get older, but older age was a really strong risk factor for finding cancer after diverticulitis. And again, what I just showed you, that odds ratio is roughly 3. So you're 3 times more likely to be subsequently found with cancer if you had complicated diverticulitis than uncomplicated. And then finally, and I think we all know this inherently, and we all think about these when we get consulted on these cases, right? Prior colonoscopy is important here. And if you've had a prior colonoscopy within the last year, you have like almost an 80% less likelihood of, again, having a cancer. And so I think that resonates with what we do. I mean, does this carve out a pathway for you? I'm not quite so sure, but I do think it highlights the key things that you're balancing. Obviously, in an older person who hasn't been evaluated, you're much more likely to put your foot down and get that follow-up colonoscopy. In a younger person who's had recent colonoscopy, you know, perhaps you can reasonably walk around it. And then the last slide is just this. If you didn't see this in the literature lately, this was just published in the Annals of Internal Medicine. It's actually a clinical guideline from the American College of Physicians entitled Colonoscopy for Diagnostic Evaluation and Interventions to Prevent Recurrence After Acute Left-Sided Colonic Diverticulitis. And the recommendation they made really goes along with the data, I think, that I just showed you. It says the ACP suggests that clinicians refer patients for a colonoscopy after an initial episode of complicated left-sided colonic diverticulitis in patients who have not had a recent colonoscopy. Again, that's a conditional recommendation, low certainty of evidence, but maybe a little bit more evidence along those lines at this year's DDW. So with that, I'll stop and happy to answer questions.